I'd like to welcome you all and thank you for coming to today's session, which is called Why the Eye? Forum on the Connection Between Mental Wellness and Vision. My name is Dr. Steven Silverstein. I'm a professor of psychiatry with appointments in also neuroscience and ophthalmology at the University of Rochester Medical Center in New York, and I will be moderating the session for today. I'd like to just give a short personal description of myself. I'm a 60-year-old man, 5'9". I have a beard that's turning white and not as much hair on my head as I used to have. And that's about all I should probably say. So before I introduce the session, I'd like to take some time to emphasize the importance of what we're here to talk about today, which is integrating mental health care and screening into vision and eye health. This connection is not always taken into consideration. And our goal today is to bring about awareness and discuss opportunities for integrating services in these areas to support people with vision impairment to achieve optimum mental wellness. Today, the session will bring together a variety of experts who will demonstrate the gaps and opportunities to integrate eye health and mental health. I'd like to briefly introduce and mention the presenters for the session, and I'll say more about them later. There are Carol Johnson, Dr. Varshini Varadaraj, Julie Grutzmacher, Melissa Taussig, Dr. Thiran Jayasundera, Rochelle Neutra, Dr. Kelly Scherer, and Larry Woodard. Before we start our session today, I'd like to go over the format of the session. We will have all the speakers present, and then at the end of the session, we'll have about 15 minutes for a question and answer session. You can submit questions through the Q&A button at the bottom of your screen. Our goal is to respond to as many of the questions as possible as time allows at the end of the session. So I would like now to go over my presentation and then to be followed by Carol. I just wanted to make some opening remarks and about why we're here today. What are we talking about? Why are we talking about this? Really, people with vision loss are more likely to experience a number of negative health and other outcomes, including some of the ones shown on the screen here, such as depression, which we'll be talking about a lot today, diabetes, hearing impairment, stroke, falls, cognitive decline, and even premature death. Having a decreased ability to see has been shown to be associated with a reduced ability to drive, of course, read, manage finances, and travel. So it can affect quality of life, certainly before years or months before people learn how to find new ways to do a lot of the things they did before. And the cost of vision loss is really astounding, including the direct costs of treating the diseases and other conditions that cause vision loss, and also the loss of income due to having vision loss, not being able to work, et cetera. Almost 20 years ago, it was estimated to be $35 billion in the United States a year, with most of that being related to treatment, but about a third of it being related to these indirect costs. But in 2022, it's estimated to be $134 billion just in the United States alone. Now, importantly, when people first access vision rehabilitation services, data from the United States indicate that the prevalence of depression is about 30%. So people with significant depressive symptoms or meeting criteria for major depressive disorder. And this has been found not only in the United States, but internationally, as studies show that have been done in Australia, the UK, Asia. On the screen now, I have a table that shows some of the findings, and they're all around 20 or 30 or higher percent. But interestingly, during the COVID pandemic, when research was done on this, the rates were much higher, closer to 50, over 40, over 50, and even close to 60%. So the thinking is that people who are dealing with the stress of having to adjust to vision loss are more susceptible, really, to not only depression in general, but especially susceptible when there are other major life stressors happening, such as having to live through a pandemic. And importantly, also, about a third of people or more who are dealing with vision loss and feeling depressed or anxious believe that they could benefit from emotional support and counseling at the time that they begin receiving services for their vision loss. Here's a quote from a paper that said, if I had someone to talk to or talk with about my loss of sight, I would have appreciated psychological help to discuss emotion problems such as anger and grief. Right now, I'd still like and appreciate this help. And many people said they felt unable to talk to the people in their lives about their concerns. A point I wanted to make about this is when people have, researchers have studied what happens to people who don't get any help, then they sometimes find that many people continue to feel bad or even feel worse over time, including that they feel like they have nothing to get up for, they're hopeless, they've lost meaning and purpose in their life, they feel sad, bitter, they can't really accept what's happening to them. So it's hard to move forward. It's like they get stuck. And again, this is the whole point of having psychotherapy or mental health counseling to help people benefit as much as they can from the vision rehab services and to learn to have the best life they can. I also wanted to mention, though, that sometimes aspects of treatment can cause further stress, such as having to get intravitreal anti-VEGF injections, as is often common in macular degeneration patients. That people find those uncomfortable, they get nervous about doing it. Sometimes they can't sleep the night or two before they have to go through the sessions. So it's not just losing vision and having to relearn so many things. It's changes in identity, it's changes in relationships, it's new stressors in life. And also there are microaggressions and outright stigmatization and discrimination that happen to people who are losing vision or who have lost vision. And this is something that's getting a lot more attention now. That's important to understand. Certainly anyone, whether you're a vision rehab specialist or a psychotherapist, it's important to understand this type of experience and the kind of effects it has on people, because it leads to social isolation, shame and embarrassment, and another number of negative outcomes. I did want to say, though, despite all that, and despite the fact that there really hasn't been that much work done on mental health interventions, we do know a fair amount about recovery from the initial depressive reaction that many people have. And this has been studied as far back as the 1950s, and more recently in Tuttle and Tuttle's really excellent book, Self-Esteem and Adjusting with Blindness. They go through a number of stages, which I'm showing on the screen now, that people often go through, not always in the same order and not always their way. But these stages essentially involve initial and then prolonged reaction to the challenges of vision loss, and then a rebuilding period. Again, optimally, this is what happens, where people reassess and reaffirm themselves as a worthwhile person, learn to cope, and ultimately have self-acceptance and self-esteem, so that you're living or adjusting with blindness rather than that defining who you are. There are some review papers now that discuss the mental health options for people with vision loss. Most of these have not been that effective, but there's active work in this field. Things like problem-solving therapy, of course, can be effective, but things that actually affect self-esteem, acceptance, and interpersonal satisfaction are still needed. Okay, so before I introduced the panel, I should have been doing this now. So let me just say again, we have an excellent panel of people today from many different perspectives, and you'll hear from all of them who are shown on the screen here. And what I'd like to do now is to introduce our first speaker, who's Carol Johnson. And Carol is a Prevent Blindness Aspect Patient Engagement Program graduate. You'll hear something about the Aspect program shortly. And she'll be sharing her personal experience with that program and in her own life with vision loss. Okay, so thank you, and I'll see you all in a little while.
Hello, everyone. I'm Carol, a Jamaican by birth, mother of 5 adult children, and married for over 33 years to a wonderful man. Is mental health considered during the medical care for a vision impaired patient? This is a great question. And the only way I can address this is to tell my story and how the journey affected me emotionally. Before sharing my vision journey, I'd like to briefly share another medical journey. Several years ago, after having my annual physical and receiving a good report from my doctor, I was referred for minor surgery to correct a problem. After successful procedure and returning to the surgeon's office, I requested a copy of my pathology report just for my personal files. My surgeon responded, "No problem. I thought you were given a copy prior to the follow-up visit, but let me step out and get you a copy." When he re-entered the room, he stated in a comforting voice, "Miss Johnson, I'm sorry to tell you, but the pathologist incidentally found microscopic cancerous cells in the margins of your discarded tissues." I asked, "How? I have no lump or growth. What does that mean?" He continued and said, "Due to the number of cancerous cells identified, you may have stage 3, possibly stage 4 breast cancer." Wow. Those words rocked my world. He gave both my husband, Greg, and myself a few minutes alone. Then he re-entered the room to let me know he called my doctor. Be it that it was so late in the day, he was told she wanted to see me in her office first thing in the morning. Upon arriving at her office before office hours, she met with us and began to explain in simple terms what this diagnosis meant and what the journey would detail going forward. I was referred for consultation to various specialists to review my case prior to having over a 9-hour surgery 2 months later. Despite the process of meeting with specialists, having surgery, and undergoing aggressive chemotherapy treatment, I was blessed to receive physical and emotional support throughout my journey. For example, during one of my chemo treatments, my oncologist wasn't comfortable with my observable mental state. And before I returned home, called my husband to tell him and to let him know that she was concerned. She gently encouraged a support group and said to reach out if additional help was needed. This conscientious move spoke dividends to me concerning her investment in my care and encouraged me to continue the fight. Let's move a little forward. A few years later, I visited my ophthalmologist for a regular eye exam. As always, he asked, "What's going on with your vision?" I mentioned that I thought he needed to increase the medicine in my prescription. Even with my glasses, I was still having difficulty seeing the words on the computer screen. He then proceeded to tell me that in reviewing the retinal images, that it was not a matter of increasing the medicine in my prescription, but there was another matter going on. He mentioned I had what is called macular degeneration. I, of course, had no idea what he was talking about. So he then started to explain that blood circulates throughout the body and there was blood vessels behind my eye where the blood was not flowing back into my body, but accumulating in pockets behind the eye. This was, in fact, what was affecting my vision. He also mentioned it's usually in senior white women and not young Black females my age. I wanted to know then, okay, so how did I get it? Did I do something wrong to get it at this age? Was it because I had radical chemotherapy and treatment for microscopic cancerous cells? Was it because I had thyroid disease, which had progressed to Graves' disease, but now it was under control? He said he didn't think that those played a factor. This just tends to show up. I told him this was weird, and I had no idea this was going on behind my eye. And all I wanted him to do was fix my problem by increasing the medicine in my eyeglass prescription, which again, I was only using because it was becoming challenging to see words on the computer screen. Okay, after taking a pause, I asked, what's the course of action? And he stated he would refer me to a retinal specialist for additional care, monitoring, and shots to slow down medical progression in the eye. The retinal specialist consultation and office visit consisted of vision examination, discussing of the cost of the shots, which 40% of my insurance covered, and subsidized costs from the drug company. I was then prepped for the shot in the eye, following the shot, my husband took me home, and for the next 2 days, it took for my eyes to settle down. There was no additional contact from the doctor's office, just the next date to come and get the shot, the next shot. Okay, how did I feel? After eye diagnosis and treatment, I had a range of emotions: fear, anguish, insecurity. I had a lot of questions. How much time will I have with my vision? What support will I have emotionally, physically? Will there be someone that I can depend on to handle the upcoming challenges, or will I have to go through it by myself, including my husband and children? How am I going to manage the financial expense? The subsidized price was manageable, but was still contingent on me maintaining my health insurance. The shots are extremely costly. Initially, I had to go every 3 weeks, then monthly, then bi-monthly. I didn't realize I would have to take shots the rest of my life, and I didn't handle this information well. Brief contrast of care. Let's look at that. Unlike the thoughtful care I received with the onset of the cancer diagnosis, as a patient dealing with vision loss, I think several things could have been considered to help with my mental care. First, at the time of diagnosis, I think it would be helpful to just share the medical condition in simple terms with a timeline for care. Why? Because it's new information that is immediately affecting the patient's way of life. So reinforce the information. Share referrals to websites, handouts, audio referrals, etc. In my case, I was given an old handout, and only after I asked for more information on the shot and my condition. Here's an example. When I had the microscopic cancer cell diagnosis, I wouldn't even have known something was wrong had it not been exposed in the pathology report. Therefore, the time between the discovery and the way it would have changed my life afforded my medical team the space to provide great support in getting me ready for surgery, recovery, and harsh rounds of chemo. As opposed to my eye diagnosis, I was already having vision problems before I received the diagnosis. The first visit involved the examination of vision, insurance verification, the shot in the eye, and payment. This can be an uneasy process. Second, beyond diagnosis of the initial meeting, consider a checkup appointment as a follow-up on the patient's condition, both their physical and mental state. And finally, as a provider, could I please suggest that you share helpful resources, provide a positive team support, such as information on organizations that can provide financial support, transportation support, support groups, which gives the patient room to be heard as they receive guidance in navigating through their experience. Support, support, support. Simply put, just knowing that your doctor is taking the time to show care is critical, and it gives hope. So equip me, the patient, to work through my anguish and have solutions to cope with the condition, because the reality is my mental state matters as much as the medical care that you provide. Thanks for listening.
Thank you, Carol, for sharing your story and also for those excellent tips for providers. Those are really good points. What I would like to do now is to introduce our next speaker, who is Dr. Varshini Varadaraj, who's a research associate at Johns Hopkins Disability Health Research Center. And she's going to share and discuss the public health case around mental health and vision.
Good afternoon, everybody. Just confirming that you can see my presentation screen. Dr. Silverstein?
Yes, we see it.
Great. Thank you for that introduction. And I'm going to talk about what we know on the connection between vision loss and mental health, and also just as importantly, what we don't know. I will begin with a visual description. I'm an Indian woman in her 30s with long black hair, wearing a gray blazer, and my Zoom background is blurred. I work at the Johns Hopkins Disability Health Research Center, directed by Dr. Bonnie Sweenor, where our focus is on shifting the paradigm from living with a disability to thriving with a disability, including for people with vision loss. To provide some public health context on the magnitude of vision loss, vision impairment is increasing over time, largely due to the aging of the US and global populations. For example, from 2015 to projections in 2050, the prevalence of vision impairment and blindness is projected to double from 4% to almost 8%. Now, why is that important? This is a framework we've published that shows that vision impairment influences functioning across multiple domains, including physical, cognitive, and the focus of this forum, psychosocial functioning or mental health. Impaired functioning can then in turn go on to cause downstream negative health outcomes for people with vision impairment. It's long been understood that there is an impact on an individual's mental health for people who start to lose their vision. This study showed that older adults with vision impairment were more likely to have depression and anxiety than their peers without vision impairment. But to understand the impact of vision impairment on mental health, we really need to be looking beyond depression and anxiety. This work showed that among people with vision impairment, higher proportions report moderate and severe loneliness as compared to the general population. And this was across different age groups ranging from 18 years to 66 and older. And this indicates that people with vision loss are experiencing social implications beyond mental health implications associated with their vision loss. Further, a paper that just came out that synthesized data across 10 existing studies on the association between vision impairment and suicidal behavior found that vision impairment is associated with suicidal ideation, attempts, and death. And these are sobering numbers and underscore the importance of eye health on overall mental health and the potentially devastating consequences of insufficient support for people with vision loss. Why does vision loss impact mental health and social well-being? There's some data showing that people say that vision impairment is worse than certain diseases and ailments. For example, in this online nationwide poll, Americans across ethnic and racial groups describe loss of eyesight as the worst ailment that could happen to them, worse than losing memory, speech, hearing, or a limb. Now, while this is important to know and supports the need for the prevention and treatment of eye and vision disorders, let's pause and unpack that for a moment. We have assumed as a society that being visually impaired or blind is the worst possible thing that can happen to somebody. And therefore, what follows, of course, is depression and anxiety. But perhaps we need to shift our way of thinking to maybe the underpinning here is people with vision impairment are depressed because the world is designed to exclude you if you're visually impaired or blind. I'm bringing back this framework to highlight there are personal and environmental factors that may change how this relationship between vision loss and mental health is operationalized in different settings. For example, perhaps this relationship differs if an individual is in an environment that is more inclusive of people with vision loss, as opposed to an environment that is not supportive and inclusive. There's two pieces I want to highlight that may be resulting in the downstream mental health consequences of having vision impairment. The first piece will be stigma and discrimination, and the second will be non-inclusive and inaccessible environments. I'll focus on stigma and discrimination first. In a qualitative study that we conducted during the pandemic with older adults with macular degeneration and glaucoma over Zoom, several themes of internalized and externalized stigma emerged. And I've pulled a couple of quotes from those interviews. A participant said, "I just don't want to have a perception of limitations. I don't want people to feel sorry for me." And this quote gets at how people with vision loss may be treated differently in society. This participant said, in reflecting on people with substantial vision loss, "I think it hurts them because they are targeted as different. They are targeted as not a whole person, as being a lesser person. I do feel that people feel rejected in general." This brings up the experience of discrimination. This study noted that adults with vision and hearing impairment experienced more discrimination than peers without respective impairments. And of the 5 discrimination domains assessed in the study, the 2 domains that people with vision impairment reported were worst impacted were being treated with less respect, and 2, others acting as though the person with vision impairment was not smart. Now let's think about this. Could these feelings of discrimination be impacting mental health? Data, in fact, do show that perceived discrimination is associated with higher levels of depressive symptoms and loneliness. Let's shift focus to the second piece that I want to focus on that is likely contributing to adverse mental health for people with vision impairment: the lack of inclusive and accessible environments. Data show that people with vision impairment are engaging in fewer activities than those without impairment, be it doing crossword puzzles and reading the newspaper, to being social and attending a movie or a game. Now, this decreased participation could be putting them at risk for future cognitive impairment as well as adverse mental health. If we were to design activities and systems that could allow better engagement for people with vision loss, what would the picture of mental health for people with vision loss look like? For starters, within the healthcare system, unlike key demographics like race, ethnicity, gender, and age, disability data are not routinely collected in electronic health records. And without that information, we cannot track inequities that people with vision and other disabilities may face in mental health and healthcare outcomes. We implemented an electronic health record questionnaire to collect data on accessibility requests at an eye clinic, and we found that over a 1-year period, about 10% of patients making an eye appointment had an accessibility need, and primarily a mobility limitation followed by a sensory impairment that included vision. Now, an accommodation need does not equate to a disability, as not all people with a disability require accommodations. But I highlight this work to stress the need to standardize data collection or disability and disability-related accessibility need requests in electronic health record data, because data are key to tracking disparities in progress. In recognizing the data as a powerful tool for change, at the Disability Health Research Center, we create what we call data dashboards that provide a range of disability information in an accessible and publicly available format. And we created the COVID-19 dashboard to highlight state-based differences in vaccine access. We assessed the accessibility of website content in terms of the number of types of accessibility errors from health departments of all US states and territories, and scored and ranked the different states. We categorized the scores into the top, middle, and bottom 1/3 of accessibility errors, and we see here just an overall picture that there was wide variation. Where you lived could factor into how easy or difficult it may be to access the vaccine if you were blind or had low vision, for example. Another aspect where people with vision loss may be experiencing inequities is food access. Food security is central to health and well-being, and food insecurity has been linked to poor mental and physical health. In national level analyses, we found that low-income adults with vision loss were more likely to be food insecure at 43%, as compared to low-income adults without vision loss at 26%. And this brings us to another one of our disability dashboards, the Supplemental Nutrition Assistance Program, or SNAP dashboard. SNAP is a federally funded public benefit providing food assistance to millions of Americans. And we developed this to assess the accessibility of SNAP websites across states in the US. And we found state-based differences in the flexibility and accessibility of SNAP websites and the enrollment process. So once again, where you live, your environment may be playing a role in how accessible basic needs like food are being met. Could this be contributing to how someone with vision loss experiences downstream mental health consequences? And before I begin to wrap up, I want to highlight how the COVID-19 pandemic widened existing mental health and other issues for people with vision impairment. This research found that older adults with vision loss were more likely to report feeling depressed during the COVID-19 pandemic than counterparts without vision loss, and that video calling, but not conventional phone calling or social media messaging, mitigated these feelings of depression. And this highlights that social engagement via video calling or seeing someone in person is crucial for mental wellness. In an online study that we conducted during the pandemic and reflecting on how COVID-19 has disrupted daily life, one participant very aptly said, if the gap exists before a major health crisis, you better believe that that's going to become the Grand Canyon when something like this happens to us. Another participant with vision impairment said, food access was as scary to me, if not scarier than COVID. Another participant with vision impairment said, the paratransit systems in my area will not deliver you or pick you up from a testing site. If you can't get there on the bus or on your own, you can't do it. And taken together, these results highlight that from depression to basic needs such as grocery shopping and public transit were all exacerbated by the pandemic for people with vision loss. In summary, people with vision impairment experience mental health impacts such as anxiety and depression and suicidal ideation, as well as related social impacts such as loneliness and social isolation. The underlying reasons are complex and multidimensional and include stigma and perceived discrimination, as we've seen some examples of, as well as inaccessible environments that are not inclusive or supportive of people with vision impairment, whether that's accessing vaccine information, healthcare services, food, transit, etc., that may be contributing to adverse mental health outcomes. To conclude, I want to remind you that every one of us, if we live long enough, will experience at least one eye condition, as highlighted by the WHO, the World Health Organization. And relatedly, as also stated by the WHO, disability is a part of being human. Almost everybody will temporarily or permanently experience disability at some point in their life. And that should make accessibility all of our responsibilities. The focus for healthcare providers, researchers, policymakers, and funding agencies needs to shift from solely focusing on fixing vision impairment and preventing or curing mental and health issues, which I don't deny is important. It's a very important part of the puzzle, but it is only one aspect. We need to broaden to thinking about the social model of disability and focus on universal design to improve the accessibility of systems, facilities, programs, and overall creating spaces accessible to everybody, to people with and without vision loss. Thank you all so much for listening, and feel free to check out the Disability Health Research Center website if you'd like to learn more. Thank you very much.
Thank you, Dr. Varadaraj. That was really a great presentation. And one of the take-home messages from me there was that we can't just think about treating depression or anxiety in some, reflexive way with just, giving medication or whatever, but it's really important to understand the different factors that people are reacting to, in their individual lives. What I'd like to do now is to introduce our next speaker, who is Julie Grutzmacher. And Julie Grutzmacher is the Director of Patient Advocacy and Population Health Initiatives at Prevent Blindness. And she's going to share key takeaways from an interprofessional task force on vision loss and mental health.
Thank you, everyone. My name is Julie Grutzmacher. I'm the Director of Patient Advocacy and Population Health Initiatives at Prevent Blindness. I am a white woman in my early 40s. I have long, brown, curly hair, and today I'm wearing a red blouse. So I'd like to provide an overview of Prevent Blindness's initiatives around mental health, and talk to you a little bit about our mental health task force that we put together a year ago, as well as the issue brief that came out of those conversations. So first, just so we're all on the same page, I'd like to provide a definition of mental health that I like a lot from the World Health Organization. Mental health is a state of well-being in which an individual realizes his or her own abilities, can cope with normal stresses of life, can work productively, and is able to make a contribution to his or her community. So the Mental Health Task Force was hatched in about a year ago, and it really came out of conversations that were had in the Aspect program. I won't spend a lot of time on the Aspect program. At the end of the slide deck, there is a QR code which you can scan and learn more about the program. But briefly, it was started 3 years ago by Prevent Blindness, and to date, we've trained 128 individuals, those with vision loss and blindness themselves due to a variety of conditions, as well as allies, be it parents, caregivers, and eye doctors, and multidisciplinary professionals. So again and again, the conversation around not enough resources were provided, not enough support around mental health just kept surfacing. And we knew that as an organization that has a broad reach and working on behalf of the patient, we needed to do something about it, Prevent Blindness. So we decided to establish a multidisciplinary group of professionals and patients, because we knew that this problem needed to be addressed from a multidisciplinary approach. And so we brought together 20 individuals. They were eye doctors, they were with a variety of conditions, be it inherited retinal diseases, glaucoma, diabetes-related eye disease, EMD, and more. We brought together parents and psychologists, counselors, and social workers, as well as a vision rehabilitation specialists. We came together for a total of 4 meetings, and they were hour-long sessions held over Zoom. All of the conversations were curated so that each one of the breakout rooms had a diversity of perspectives represented. So we had patients in that same room with ophthalmologists and optometrists, as well as mental health providers. And through all of those conversations, we summarized what we learned in an issue brief that was published just last month, June of 2023, about a year after we had established and held those focus group meetings. It summarizes this issue brief, what we learned, and it's really geared towards a policymaker audience, providers, professionals, and program personnel. The questions that we asked each time were different, and the participants received the questions ahead of time. So the first meeting, we asked the group, in what ways does vision loss affect mental health? What gets in the way of providers asking patients with vision impairment about their mental health? And what are the barriers? In the second meeting, we asked the group, from your perspective, what are the top 2 to 3 things providers could do to help reduce psychological distress among patients with vision loss? And we asked this around the time of diagnosis, beyond diagnosis, what resources would be helpful for providers to know about? How can a referral to low vision therapy improve a patient's mental health? How can a mental health or psychiatric referral be helpful? And lastly, how might incorporating a 2-question depression screening tool into the electronic health record be helpful? The third question we asked was, from your perspective, what are the top 2 to 3 things patients can do to help reduce psychological distress? We asked this around the time of diagnosis and then beyond diagnosis. We asked what resources would be helpful for patients given a new vision-threatening diagnosis. Lastly, at that 4th meeting, we asked the group to respond to the question, how are the mental health needs different between individuals born with vision loss versus those who lose sight later in life? And how should we tailor our resources to meet the needs of these types of patients? So the key barriers, there are 5 that were identified by the group, are awareness, limited time, shortage of trained providers, stigma and lack of referrals, and I'll go into each one of these. So first, awareness. And this was really around the idea that the group had said that the eye care providers are not informed of local or national mental health related resources, and they might not have a referral network. Around limited time, of course, an issue that comes up again and again across all sections of healthcare, but the insufficient time to ask about mental health and to really address it is real. The shortage of trained providers, specifically, it was identified by the group that mental health providers really lack the special training and expertise to be able to counsel those with visual impairment and blindness. And then stigma, of course, comes up, and that is, both at the individual level, at the provider level, and societal level as well, and that impacts care and help-seeking behaviors as well as referrals to mental health providers. And then lastly is the lack of referrals, and specifically the group identified that there's a real insufficient referral happening for vision rehabilitation, and this is both contributed to from the provider perspective as well as the patient perspective. There may be a reluctance among eye care providers to accept that medical treatment is no longer helpful, and to also know that a referral to vision rehabilitation could be equally beneficial during this time, even through the treatment phase. So the key themes that were identified by the group around the topic around the intersection of vision health and vision loss and mental health fall into 4 categories, and those are change or loss of identity, loss of independence, emotions tracking and recall, and grief and coping. And I'm going to go into each one of these in detail. So first, change or loss of identity. The group identified that individuals who develop vision loss and blindness in adulthood might not be able to do the things that they once did, or at least not in the same way. And that involves a loss and a shift in identity. A couple of examples that were given was a nurse who had worked for over 30 years, who had a retinal detachment and was no longer, after the surgery, was no longer able to return to her work. And so that was a huge change in her identity. Another woman had talked about just being an avid photographer for over 40 years, loving it so much, but having to give it up due to her progressing vision loss from AMD. And then loss of independence was a second topic that came up among the group. And they talked about how acute depression and anxiety among those with vision loss and blindness is often a reflection of losing independence and adjusting to new life circumstances. And therefore, it really is important to consider resources that might help patients safely regain their independence and self-efficacy. One example that was given of just a simple way in which independence had occurred was a woman with AMD used to taking care of all of her banking and financial information, all of a sudden couldn't deposit checks through the ATM or withdraw cash because she could no longer see the keys. And then emotions tracking and recall. This came up again and again in the conversations, was that patients may not initially grasp all during an office visit when a new diagnosis is made. And this is really due to the flood of emotions that can come in. Examples are shock, fear, devastation, anxiety, and anger. And so that interferes with the ability to remember medical information, and that it's really hugely beneficial potentially for patients to have a little bit of extra time to engage in both the emotional and cognitive processing. It was also recommended by the group that just a week after the medical appointment to just check in. Do you remember what was said about your diagnosis? Do you have any questions, to really gauge cognitive processing and to have time for that, the diagnosis to set in. Grief and coping came up as well, and that there's a real difference between vision loss from gradual or progressive conditions So anticipatory grief, really anticipating your visual happen, that's different from, the coping and the grief related to that is different from perhaps a trauma or an injury related incident. And the coping and the grief related to more congenital conditions, that's also different. And that we need to acknowledge that there's difference there so that we can better help those individuals. But far and away, the key takeaway here is that no matter what the circumstances are, that patients can benefit from being asked about how they're coping and what supports they have in place. So questions that the group identified that could be really helpful for providers to ask their patients that would communicate empathy and not take a lot of extra time. 3 questions here. One is, I imagine it's hard adjusting to your vision loss. How are you holding up? This normalizes the grief and loss process and shows that you care. Second question is, would you like to talk to someone about how you are feeling? This gets around the stigma that was identified by the group. And phrasing it in this way can really make it easier for an individual to accept care. And then the third question is, tell me about how you previously coped with difficult situations. Asking this question really reminds patients of how they've handled difficult situations in the past, and that can be incredibly empowering for them. And then we identified 4 different opportunities for process improvement and advocacy. The first is awareness of vision rehabilitation services. So the group really determined that we need to increase the awareness among providers and patients about vision rehabilitation services, what they are, what's incorporated in these services, and how it can help. And then we need to really share the success stories with providers who made those referrals about those patients who went and really benefited from those services. Resource development and dissemination was another opportunity. And we really need to increase the availability and resource sharing between providers, patients, and organizations. And then training for eye care, primary care, and mental health providers. We need to increase the training specifically around empathetic communication, the grief process, and the patient journey, and of anticipating vision loss or blindness. And then lastly is considered the gold standard, which is the integrated eye care model, which is a recommendation by the task force. And this is ideally a team that is housed in one place, working together, multidisciplinary. It could be patient navigators, it could be peer support teams, mental health providers, eye doctors, everyone coming together for the care of the patient and being housed under one roof. And it's done in other places in healthcare, and we really need to adopt it more prevalently in eye care. And lastly, the next steps for Prevent Blindness already begun to outline the agendas for some training modules for mental health providers so that we can fill that gap of knowledge and efficacy around counseling the visually impaired and blind. And we also wish to partner with schools of optometry and ophthalmology residency programs to provide training on mental health, vision rehabilitation, and trauma-informed care. There are 2 QR codes listed on the slide. On the left, it is the Aspect program, and the right is the mental health issue brief. So feel free to scan this. The slide deck will also be on the website. But thank you so much for your time and attention.
Thank you, Julie. That was a great summary of that, the task force's work. And I hope that that document gets distributed far and wide. There's really so much great information there.